So thank you very much, Alexandra, and thank you to all of you for inviting me to participate in your conference. I am sorry that I cannot be there in person. I would have loved to have had that opportunity. But COVID has taught us that we can do things in other ways. So as Alexandra outlined to you, I am going to talk to you today about vertical transmission of HIV. And I've been asked the specific question is, are all preventative components still required? So first of all, with regards to my disclosure, I have worked with all of the companies that are involved in the manufacture of HIV products and have served on their advisory boards, spoken at CME events, and conducted clinical trials. So I just wanted to start a little bit with a global picture of HIV and the proportion of new HIV infections that are still happening in children aged between 0 and 14, as you can see at the bottom line of this graph. And clearly, most children who do acquire HIV do so in the context of vertical transmission. So I think, first of all, 2 points is one, the proportion of new infections over the last 2 decades that have been attributed to vertical transmission has declined from 18% to 11%. And the absolute number from 520,000 persons to 160,000 persons. So yes, we've done well, but no, we haven't done enough. And the WHO has made some targets with the minimum prevention of mother-to-child transmission set by the World Health Organization. And it is hoped that we will have less than 50 new pediatric infections for every 100,000 live births, and that we'll have a transmission rate below 5% in breastfeeding populations and below 2% in non-breastfeeding populations annually. So that is now our goal in the prevention of vertical transmission. So first of all, let's reflect back upon when does vertical transmission of HIV most commonly occur? And this graphic representation divides it into those infants who are fed by formula and those infants who are fed by the breast. So infants who are fed by formula feeds, the vast majority of transmission occurs during the intrapartum period, during the phase of labor and delivery, with a smaller percentage during the pregnancy. And again, during the pregnancy, most of that transmission happens late in the pregnancy, more than 28 weeks, with a very small percent occurring in the early phases of pregnancy. We contrast that to then the breastfed population, where more transmission, or up to a third of transmission, does occur during the postpartum period, during that period of breastfeeding. And in that situation, the vast majority of it is happening within the first 6 months after birth. So there are a number of factors that have been defined over the years that may increase that risk of vertical transmission. So first of all, I think the main factor by far is the viral factors. And clearly, the viral load in the mother is probably the most important factor or most important risk factor for vertical transmission. There is some evidence that the particular viral phenotype, the viral genotype or clade, and the presence or absence of drug resistance may be playing a role. Then there are maternal factors, largely related to the health of the mother, which may be her immunologic status as it relates to her CD4 cell count. It may be due to her clinical status related to the presence of opportunistic infections, may be related to nutritional factors, such as having adequate food supply or vitamin deficiencies, and then certain behavioral factors, including being exposed to HIV infection during pregnancy. There are the infant factors that I alluded to earlier, so that if an infant is going to be fed by the breast, then there is an increased risk of transmission. and that would also depend upon the GI factors. And this is why we've sometimes seen that an infant who has mixed feeding as opposed to simply breastfeeding may in fact have even higher risk of transmission. There may be some fetal factors. So prematurity has been associated with an increased risk of transmission, as have some genetic factors and multiple pregnancies. And then the last thing is really the obstetrical factors, including the mode of delivery, prolonged rupture of memories, and various procedures during labor and delivery that may be associated with more risk of blood-to-blood transmission. So there are a large number of factors that can influence the underlying risk of maternal to child transmission. But perhaps our greatest achievement in this area was in this pivotal trial called the ACTG 076 study, which was the first study to demonstrate the role of antiretroviral drugs in decreasing the risk of maternal child transmission. And I was around back when this study was conducted. I'm not so sure how many of you. And it's very interesting when we go back and we review this study and how this study was designed and why they came up with the various components. There really was not a whole lot of strong evidence as to why all of these components were included. But just to review briefly, that the mother did receive oral AZT during the pregnancy. And at that time, we were using 100 milligrams 5 times a day. That was a lot of AZT that made a lot of moms sick. And 5 times a day is really hard for somebody to be adherent to. Then the second phase of this was during labor and delivery, where the mother received a loading dose of IV AZT and then a continuous infusion until the umbilical cord was clamped. And then the third phase was that oral AZT syrup was given to the baby every 6 hours for 6 weeks. So these are the 3 components of the preventative therapy that had been designed in the 076 study. The rationale was really not that strong. Why we used this is that this was really the standard dose of AZT that we used at the time, and we clearly know that that is different now. The reason for the IV AZT during labor was in order to maintain drug levels during labor and delivery, and averted the need for any oral medications during labor and delivery when it may be really hard for a woman to take AZT. And this was really derived from pharmacokinetic studies. And then the reason for this component is that it was, again, based on in vitro data in that infected maternal cells could persist in the infant circulation after birth for up to 6 weeks. The other important thing that we have to remember from this trial is that this regimen was started between 14 and 34 weeks of gestation, and for women whose T counts were greater than 200. Those were the entry criteria. And part of this, again, is that we did not want to do harm. So we did not know about the safety of this drug in pregnancy. And so the issue was that it was deferred until after the first trimester of pregnancy. But remember in this trial that some women, in fact, were enrolled quite late into up to 34 weeks of gestation. Nonetheless, this worked. And I think this is probably one of the greatest success stories that we've had with the use of antiretroviral drugs in our history of having these drugs available, is that the role of AZT monotherapy was decreasing that risk of transmission from 25%, which was the baseline risk, down to 8%. And some of the commentary that was published in the journal, in addition to this study, is that a door is opened and how great we did at bringing down this risk. But, you know, we always criticize clinical trials, and what we do in clinical trials is sometimes not what we do in the real world. And part of the controversy at the time was, well, yeah, this worked great in a clinical trial. Does it work in real life? And in fact, it worked even better in real life than it worked in the clinical trial. And although this risk in the AZT arm was 8% in the trial, it actually became about 4% in real life when people use this in their own clinics. So then the question is, why did it work? Well, it wasn't the impact on viral load. So at the time, we thought maybe this is what was happening, right? We thought that AZT was bringing down the maternal viral load, but we know that AZT monotherapy doesn't do very much at all in terms of reducing maternal viral load. And in fact, when we look here at the plasma RNA in women over time, you can see that there really is very little difference between the AZT and the placebo arm. So what we really believed was happening is that there was AZT in the baby's bloodstream before they became exposed to the virus. So this was really a form of pre-exposure prophylaxis rather than anything else. And then, as I alluded to before, mode of delivery could be important, as we know that women who delivered vaginally were at higher risk of transmission of HIV to their babies than those who had cesarean sections. And in fact, there was this study that was published in The Lancet in 1999 that compared the role of vaginal delivery versus cesarean section in those who did or did not receive AZT during pregnancy and based upon their CD4 count. So if we look at the ladies who did not get AZT during their pregnancy, you can see that the cesarean section cut down the risk of transmission by almost 30%. But if they did receive AZT during pregnancy, although there is still a benefit and it is still statistically significant, that added benefit of the cesarean section to the AZT was much less, but it was more important in those who had lower T cells than in those who had higher T cells. So that in 1999 was really the state of the art, is that we use this triple phase of therapy during labor, during gestation, labor and delivery into the baby, and we used a cesarean section. But as all of you know, we've made lots of changes over the years. And so what has happened is, to the mom, we no longer consider AZT monotherapy appropriate, and we truly have changed our treatment of moms with the times. So we went to bitherapy initially and then on to combination therapy. We also learned that transmission can happen early in pregnancy, and I demonstrated that in one of those initial graphs. And therefore, we do not wait until 14 to 34 weeks of gestation in order to initiate the antiretroviral therapy. We start it right at the early phase of therapy. And then the C-section part now, we only do if the viral load is not suppressed at the time of delivery. However, all of these changes have been made on the basis of expert opinion, and there have never been any other randomized controlled trials of other antiretroviral drugs versus placebo, or even against AZT monotherapy, nor will they ever happen. So what are our new goals? Our new goals is we want to optimize therapy for mom, we want to prevent adverse reactions in the fetus, and we want to prevent transmission. And so what we have learned over time is that maternal RNA level is important and antiretroviral use is important, and the two are independent factors. So in this plot here, we see increasing maternal plasma RNA, and in this graph, in this side of the graph, from AZT monotherapy down to heart. So in the absence of AZT or any therapy and a very high viral load, we have high rates of transmission. In the setting of combination antiretroviral therapy and an undetectable viral load, then the risk of transmission falls dramatically. And we've seen this in the field, and I think many of you have seen graphs like this over time, is that the trends in the rate of mother-to-child transmission over time has come down to virtually zero. So if a mother is on effective antiretroviral therapy at the time of delivery, the risk of transmission to the baby is virtually zero. And that's part of what's raised these questions about, well, do we really need all three of these components in order to achieve this goal? So globally, as I started in the early part of my discussion, is that we have dramatically decreased in the field the number of children who become infected with HIV through maternal child transmission. And this decline has occurred both in high resource settings where formula feeding is the norm, and it has also occurred in the lower middle income countries where breastfeeding is much more common. So this is data that I've taken from the Clinical Infectious Disease Journal in 2017, and it's based upon a study in the United Kingdom where they have looked at their rates of maternal child transmission over time. And in their final time period of study between 2012 and 2014, they had only 7 infected infants born in the UK to women living with HIV. So for a percentage of 0.27%, so virtually 0. During this period of time, 60% of the women were on antiretroviral therapy at conception. 87% of these women had an undetectable viral load at the time of delivery. And among those whose viral load was undetectable at delivery, this risk of maternal child transmission was even lower at 0.14%. So demonstrating that we can eliminate maternal to child transmission with the appropriate use of antiretroviral therapy. I alluded to earlier that in that early study of AZT monotherapy, we waited until after first trimester, and we did that because we were concerned about the teratogenicity of the drug. However, that does need to be balanced against that potential risk of transmission in those early stages of pregnancy. And so again, over time, we've had more confidence that the antiretroviral drugs can be safe in the first trimester of pregnancy. And by using them earlier in pregnancy, we can further decrease that risk of perinatal transmission. So again, this is data that's coming from the Clinical Infectious Disease Journal. In this case, a study from the French perinatal cohort, where they have this incredible cohort that does follow all of their HIV-infected women through their pregnancies. So this particular study that they're reporting is based on over 8,000 women on antiretroviral therapy, and they were looking at transmission rates based upon when antiretroviral therapy was started. So in these graphs, you can see that if antiretroviral therapy was started in the first trimester, then that risk of transmission was 0.4%. If it wasn't started until the second trimester, it increased to 0.9%. And if it wasn't started until the third trimester, now the risk of transmission was 2.2%. So their conclusion is that it is much more effective to initiate antiretroviral therapy as early as you can in pregnancy. And these results held firm regardless of whether or not the woman was suppressed at the time of delivery. So therefore, preconception antiretroviral therapy, in fact, had the greatest efficacy. So these were women who were already on HIV therapy before they became pregnant. Now the rate had decreased to even 0.2%. And so this is based upon 2,600 women who had antiretroviral therapy before they got pregnant and had an undetectable viral load at delivery. So the message and the way we've changed our practice now, and of course, in practice in general, if you have HIV, you treat it. And for women, if they're contemplating pregnancy, we put women on antiretroviral therapy even before they become pregnant in order to further minimize that risk of transmission. Sorry, had a little computer problem there, no problem. Okay, so this again is more data following on this concept from the French perinatal cohort that U equals U. Undetectable is untransmissible. If women are on antiretroviral therapy at the time of delivery and have a suppressed viral load and are not breastfeeding, then virtually we can say that transmission will not occur. And this is such a wonderful thing that we've been able to share with our women over time, is that, yes, you can have an uninfected baby. And I think this is really one of the best pieces of news that I've been able to deliver in my practice. Okay, so that's in the setting where women are babies are formula fed. What about the situation in those parts of the world where formula feeding is not possible because of economics, or because of the fact that breastfeeding may be very important in order to prevent diarrheal diseases and other infectious complications? And so this is data from the PROMISE study, and this PROMISE study has been published in the New England Journal of Medicine. And these were situations in which the antenatal component was a randomized of women receiving different forms of antiretroviral therapy, and a postpartum component based on babies getting nevirapine or the maternal continuing their antiretroviral therapy. And the bottom line of these studies is that the overall transmission rates with the mother being on antiretroviral therapy in a breastfeeding population was 1.3% at 24 months. So this demonstrates, with the use of antiretroviral therapy in the mom and in the baby, that even with breastfeeding, that we can decrease that risk of peripartum transmission to a very, very low and acceptable percentage. So let's get back to the question at hand. We're talking about these three components. We're talking about antiretroviral therapy to the mom. We're talking about what happens during labor and delivery. And then we talk about what happens to the baby. So I think my discussion so far has convinced you, and I think we all would agree, that the component to the mother is absolutely important. That putting mother on combination antiretroviral therapy as early as possible in pregnancy and having a suppressed viral load at the time of labor and delivery is the most important factor in terms of preventing mother-to-child transmission. So then the second question is, what about that labor and delivery part? Okay, and there are two components there. Is one, what is the importance of the role of the cesarean section? And secondly of all, what is the role of the intravenous AZT? And so I think in my earlier discussions, I was able to show to you that if you can demonstrate that the woman has a suppressed viral load at the time of delivery because of antiretroviral therapy to the mom, that the additional benefit of the cesarean section is very small. And so I think that most parts of the world now, in the developed world for sure, if the mother has an undetectable viral load at the time of delivery, we do not recommend cesarean sections. If the viral load is still detectable, and people argue whether that number is 500 copies per mil or 1,000 copies per mil, that a cesarean section should still be performed. So then the question is, what about the intravenous AZT? And this comes up as a big discussion all of the time because we don't use AZT in moms very much anymore. And so mothers are on, different combination pills, most of which do not include AZT. Do we really need to give them that intravenous AZT during labor and delivery? And that becomes a very tough question. And so, what evidence do we have? And again, this is data from that French perinatal cohort that I discussed previously, and that they looked at HIV-infected women, over 13,000 that delivered between 1997 and 2010. And some of these women, most of them, received intravenous AZT, and about 500 of them did not receive AZT, and there's various reasons why these women fell out of the study. And these were their findings, that if the viral load was undetectable, the transmission rates between those who did and did not get the intravenous AZT was not that different. For those individuals who had low-level viremia, again, the difference was not that remarkable. But clearly, for those individuals whose viral load at delivery was greater than 1,000 copies per mil, you can now start to see differences in rates of transmission. So it was data such as these that have led many of the guidelines to change their philosophy around intravenous AZT. And in many settings, if the viral load is undetectable at the time of delivery, people do not recommend the intravenous AZT anymore. But that is all dependent upon viral load. And as I alluded to before, if the viral load is high, then the evidence is in favor of using the intravenous AZT. If the viral load is low, then generally not, because of these studies that are showing very low risk of transmission. But there is a caveat to these studies, right? So the studies that I alluded to were not based upon a randomized control trial. They were based on what happened in real life. And they do not have the clinical power to say absolutely no. And the definitive proof would require a randomized control trial of over 10,000 pregnancies. So our recommendation is based on these cohort studies and observations that we've seen, but they are not the definitive evidence that we need. Now, the problem with using this in practice, however, is how do you know your woman is undetectable at pregnancy? Well, many of us have women that we follow very carefully. We follow them all the way through their pregnancy. We do routine viral load testing, and we pretty well know that they've been undetectable through the entire pregnancy. Nothing has changed in terms of their adherence, and that we clearly anticipate that they're going to be undetectable at the time of delivery. But that's not always the case. And what happens is sometimes women will go and deliver in a hospital where she hasn't had her HIV care. They have no idea whether or not her viral load is undetectable at the time. And then there are other women with lots of disorder in their lives. They get towards the end of pregnancy, they lose their adherence to antiretroviral drugs, and we may or may not know whether their viral load is actually undetectable at the time of delivery. So you really have to take this on a case-by-case basis as to whether or not you believe that the woman is undetectable or not. And what is the point of the intravenous AZT? It's trying to get that drug into the baby before that baby is exposed to virus. And that's the whole concept behind this. It's kind of as a pre-exposure prophylaxis to that baby. And so what are recommendations? And I've just selected the one from the DHHS, which is one of the recommendations in the United States. And their recommendations is if the viral load at delivery is greater than 1,000 copies, that IV AZT is recommended, as well as a cesarean section. If there's premature rupture of membranes, then there's probably no advantage to that cesarean section. If the viral load is 1,000 copies or less, it is said that IV AZT is not required if you're pretty sure the mom's on treatment with an undetectable viral load. If she's got low-level viremia, you may want to reconsider the situation. But as I alluded to, there are some challenges to all of this. Is first of all, getting that antiretroviral therapy initiated as early as we can during pregnancy, ensuring that they have good adherence during pregnancy, carefully monitoring them to be sure that the viral load is suppressed at the time of delivery. And we're doing better. Okay, so in terms globally, in terms of pregnant women being on AZT, we're doing better. We're not great though. Okay, and there are still many women throughout the world who do not have access to antiretroviral therapy in order to prevent maternal-child transmission. And this needs to be an area that we continue to need to work towards and to strive towards. But I think one of the bigger controversies today is, what about that third component? Do we still need to give antiretroviral therapy to the newborn? And again, there are two scenarios: in the newborn who's being formula fed and the newborn who's being breastfed. And so I've shown you lots of data now that if the mother has an undetectable viral load at the time of delivery, we believe in the concept of U equals U, and that perhaps the baby has not been exposed to HIV, and therefore are we giving the baby something that they don't really require? Well, what do the guidelines say? Well, the guidelines say we still do it because we just don't know. There is some controversy as to how long we treat the baby. So some of the guidelines say if we're dealing with a low risk situation, and that is defined as a mom who's on HIV therapy and has an undetectable viral load, then it is recommended that the baby go on 4 weeks of AZT syrup alone and just follow up with some HIV testing. In contrast, a high risk situation, which is a mom who's not on treatment, or a mom who just got treated at the time of delivery, or a mom who has a detectable viral load at the time of delivery, now the recommendations are 6 weeks of antiretroviral therapy, and in this case, combination antiretroviral therapy with 3 drugs followed by HIV testing. Okay, what about a presumed exposure? So these are women who test positive at delivery, and the newborn has an antibody test that's positive. So again, is this passive transmission or is this infection? So again, the recommendations are the same, but if you turn out finding out that mom is actually negative, then you can stop. And then obviously a baby who is newborn with HIV needs to be on permanent antiretroviral therapy. So those are what the recommendations, but this is where there's controversy, and particularly this scenario number 1. Scenario number 1, mom is on antiretroviral therapy. She has an undetectable viral load at delivery. We believe in U equals U. Does that baby need this 4 weeks of AZT syrup? We don't know. But the Swiss, who are always the ones that are more aggressive, and they were the first ones talking about U equals U and the lack of a need for condoms to prevent person-to-person transmission, they have also gotten very bold in terms of their recommendations in the prevention of mother-to-child transmission. And they are saying that in the situation where the mother receives antiretroviral therapy during pregnancy, and that breastfeeding is not happening, that perhaps you do not need to treat the baby with antiretroviral therapy. So this is a situation that they are following. It's not necessarily a situation where the rest of the world is following. This is not a situation where there's actually randomized controlled information, but this is the plan that they are following. And we must remember that giving antiretroviral therapy to babies is not without its potential harm. And I think that we know now by treating moms during pregnancy that there are many, many children who are going to be exposed to antiretroviral therapy, but never become HIV infected. And we call these HIV exposed uninfected. And the number of children in this scenario is going to continue to rise. And it's been estimated that in countries with very high rates of HIV prevalence in pregnant women, that up to 20 or 30% of children may be exposed to these drugs during pregnancy. And the question is that harmful? And the problem is we're still debating this and we don't know, because it's really hard to define the appropriate control group. But there is emerging literature, and I've just quoted a couple of studies here that suggests that children that may have been exposed to antiretroviral therapy during labor and delivery and afterwards may have higher rates of mortality, may have higher rates of infections, including diarrheas and pneumonias, than those who have not been exposed. So I raised the question, is this really time for us to have a clinical trial? Is it time for us to do a randomized controlled trial as a global community to say, okay, we have a scenario, we have mother adequately treated, we have undetectable viral load at labor and delivery. Do we randomize their children into getting this postpartum antiretroviral therapy or not? Well, you can well imagine if we tried to set up this trial. So the first problem is going to be in our ethics department. We've shown that this is a preventable infection. We've shown that the risk of transmission can be described as 0. Are women, ethics committees, the world ready to take any risk that by removing that third component that we could increase the risk of transmission? But there is a balance, and I would suggest that there is some equipoise, that there is some potential toxicity of giving these babies antiretroviral therapy for 4 to 6 weeks or having exposure during pregnancy. If transmission rates are close to zero, think of the sample size of this study in order to demonstrate that we are changing the risk of transmission, and what risk of transmission are we going to accept. So I'm afraid that if we were going to do this clinical trial, we're looking at hundreds of thousands, if not millions, of pregnancies. And that would be an extremely difficult clinical trial to do. And then, of course, we've got the confounders, which include the maternal adherence to antiretroviral drugs, and then the role of breastfeeding, which may or may not be disclosed during that clinical trial. And then there's the legal implications, okay? We've shown that we can prevent transmission. If a child was born and ended up being transmitted, could they sue their parents for having acquired HIV? And I guess the question is really, what risk is acceptable? So what are my conclusions? I think, first of all, and without a doubt, the use of antiretroviral therapy in pregnancy has markedly decreased the incidence of maternal-child transmission of HIV. That viral load at the time of delivery is the strongest predictor of that transmission. Prevention has included 3 components, but I think I demonstrated to you that that was based on theory and not on any clear evidence. And which is the most important has never been studied, but I do believe that the prepartum component has to be absolutely crucial. The role of IV AZT in cesarean section in somebody that's well controlled, I think the evidence is pretty strong that it's not required. The third component, we do not have evidence. We have opinion. I've shown you that the Swiss have recommended in that situation that perhaps we do not need that third component, but residual transmission can occur. And so I think this is a discussion that you need to have with your patient, and individualized therapy needs to be thought about. So I thank you for your consideration and your thinking, and I think that we all need to take this back and consider it within our own context as to whether or not all those components are necessary. So I thank you for your attention.